So I'm going to refocus us on reducing cardiovascular risk. And some of the data has already actually been presented by Jack and Xavier on TNF and cardiovascular risk. So this is just a slide to remind us that we have large epi studies that do tell us that our diseases are associated with increased risk even after adjusting for our traditional cardiac risk factors. Chronic inflammatory burden is obviously the theme that implicates in many of the comorbidities, but however, the mechanism is still unclear, and we are researching that desperately. So the risk factors that we all know about that increase traditional risk factors, but it's quite complex because there's other things that we do for our patients. So we treat them with steroids, as we learned, can increase our risk, and then also chronic NSAIDs that I'll talk about a little bit later. And then the whole idea of disease, sort of specific, the duration of disease, and people that maintain on active disease over time, what is their risk compared to those that we can get their disease inflammation down. So here's just a reminder that there are over 20 observational studies out there showing a increase in your SMR, your mortality ratio. There's also 3 larger studies that have been done. I'm just highlighting the Nurses' Health Study that was done in Boston, looking at over 100,000 nurses and showing a relative risk of MI of 2.0. I mentioned early versus established disease, just similar to what we've learned in internal medicine about diabetes, that we do have a cardiovascular risk that's present early in RA as well as established RA. People in early RA are more likely to be hospitalized for an acute MI and more likely to experience that silent MI or unrecognized MI. We also know seropositivity, looking at anti-CCP antibodies. There's numerous studies highlighting that ischemic heart disease is increased compared to those that are CCP negative. Also some genetic studies that have done looking at risk stratification. I'm just highlighting one of them looking at over 180 patients, looking at their baseline HLA phenotype status along with things that we measure, erosion, SED-rate, CRP. There was about 21% cardiovascular events in this study, and when they looked back, it looked like SED-rate, CRP, as well as the DRB 10404 was related or associated with higher cardiovascular mortality. I'm focusing my talk mostly on RA, but also in the PSA world, there's also some large epi studies also showing similar results of increased cardiovascular risk compared to those without psoriatic arthritis. So what is this link that we all know of from these observational studies? What have we learned so far? So this is an article that got me interested in the field. It's a New England Journal article by Ross that really made me understand a little more of being a mini cardiologist. And that's really looking at, if you follow these pictorials on the vessel wall, if you look here, it's really all starts at the endothelial layer, which is usually a one-to-one cell, just smooth contact layer. And it's when that layer gets disrupted by a whole series of inflammatory reactions that really create that foam cell to form then that fibrous core and necrotic core, that cap. And then many people can live for a long time with a 40 or 50% stenosis, but it's until that somehow another inflammatory event that causes plaque rupture, which then causes the end results of a myocardial infarction that we know about. So the impact of RA treatment, this has been really reviewed in the last 2 talks, so I'm just going to go through this briefly, but looking again at some of the large systemic reviews and meta-analysis showing whether or not TNF reduces. It looks like it is associated with reduced cardiovascular event. This was shown before one of our larger databases in the US, the CORRONA database that Xavier had talked about. So as you know, the TNF compared to methotrexate compared to non-methotrexate. So TNF does show an increased risk. However, methotrexate did not correlate with reducing cardiovascular risk in this particular cohort. So I think we still have a lot to learn. There hasn't been many prospective studies looking forward following these patients. Obviously, as Xavier has mentioned, there is a lot of bias in that confounding by indication, in that the fact that people are on TNF also makes them a special type of RA patient that we need to remind ourselves. I do want to go over some medications that we all use commonly. This has been very controversial controversial. So aspirin is not controversial in secondary prevention, meaning if you had some heart event, that we know that the use of aspirin is helpful. Where I think there's a lot more controversy is primary prevention. So what do we do in our patients that we think are at increased risk? And whether or not they should be started on low-dose aspirin, I think is a lot more trickier. We do know that at least compared to 325 and 81, a baby aspirin 81 does have the same effect on lowering cardiovascular risk, but however, we have to balance that in each of our patients in terms of the overall GI bleeding risk, and what is the sort of risk-benefit ratio of starting someone on low-dose aspirin, because the risk of GI bleeding does go up with even low-dose aspirin. The other things we use commonly is NSAIDs. We know that many people use it over the counter. We prescribe prescription NSAIDs. There has been a black box warning, as we all know, about potential cardiovascular and GI adverse events with these drugs. We also know that in 2007, the FDA issued an advisory about low-dose aspirin in interaction with ibuprofen. So these are all drugs that we use every day, and if we don't talk to our patients about it, they can also take these drugs over the counter. So it's really unclear also between the NSAIDs whether COX-2 are either equivalent or safer than non-selective traditional NSAIDs. So hopefully the next time I come to talk to you, I will have some more data. We are underway with actually finishing with enrollment with something called the Precision Trial, which is actually the first of its kind, a prospective randomized trial that we are involved with, looking at these three NSAIDs, commonly used NSAIDs, celecoxib, ibuprofen, and naproxen. We did data lockdown about 4 or 5 months ago. We have enrolled about 22,000 patients, and we are trying to finish following up for 3 years. And we are randomizing them to one of these three NSAIDs and following them for cardiovascular events. So there is no current data that I could show you between comparing these NSAIDs. Given this uncertainty, what do I do in practice with NSAIDs? I do still have my patients on them. I do some extra vigilance. I think blood pressure is really important to control. So if you do put them on and their blood pressure changes, then that's something that needs to be addressed. And I do try to put them on a lower dose whenever possible. So how do we screen? Should we be screening as rheumatologists? This question comes up many times. Are we the ones? Should the primary cares be doing it? Should everybody with rheumatoid arthritis have a cardiologist? So these are the questions that occur. We know that in our general population that the Framingham risk score helps predict people's risk 10 years from now, so not your risk this year or next year. And if you answer all those questions, you become, if it's less than 10%, it's low risk, intermediate risk, and then high risk, as you see there. We also know in the European, they use a heart score or score method similar to our Framingham risk. And then there's also other standard tools that we're using. But unfortunately, all of these standard tools have been used in our patients with rheumatoid arthritis and psoriatic arthritis. And unfortunately, they truly underestimate our true risk. So probably not the best only thing to count on for our patients. We noticed that in one study that the increased cardiovascular rate in women was double than that predicted by the Framingham scores. In addition, you might have heard of the Reynolds risk score, which brought some excitement because it does add or include a CRP measure in the risk score calculation, so hoping that would help us in our population. But unfortunately, that did not improve the ability to reclassify or predict who would develop cardiovascular disease also in our patients. So there are other groups, some led by Dr. Gabriel, called the ATTACK RA, that's looking at other screening risk factor modification measures for our population specifically. So other studies that I think are really interesting also, just to highlight, I'm sure many of you guys have seen studies comparing non-diabetic controls with people with diabetes and RA, and as you can see here, we are very comparable to patients with diabetes in terms of our independent risk factor for cardiovascular disease. In terms of consensus statement and what we can follow, the the one that gets a lot of press is the EULAR recommendations, which have 10 recommendations. I didn't list it all today. I just wanted to highlight 3 in that annual assessment is considered aggressive suppression of the inflammatory burden, and then this unique sort of 1.5 multipliers, how they adjusted, which means if you have 2 of 3 of these criteria, then you can multiply your score that you're using by 1.5 to have perhaps a more accurate risk in your patient population. Other novel studies that I wanted to review, what else are we doing to try to find within our types of patients who might be at bigger risk? What can you do in your practice? So I don't have time to go over all of the cardiovascular imaging, but this is a really hot area. They are trying really hard to look at other measures where we can pick up subclinical atherosclerosis earlier. I'm just going to highlight a little bit of IMT. This is, as you know, many studies have used this, looking at that intimal layer and how it gets affected by ultrasound. Unfortunately, this can be operator dependent, and not all sites agree on how to measure, where to measure, how many measurements to make. But this is a rather low-cost alternative compared to some of the other imaging modalities, and has had a lot of publications. This is just a publication from our group that looked at the difference between psoriasis and psoriatic arthritis to see if IMT is different or there's any incremental increase. So as you can see here on this one, this is looking at an IMT that's considered normal at 0.45. And then here on the opposite side here, you see one of our patients with psoriatic arthritis. And what we found is people with psoriatic arthritis actually do have worsening IMT, as well as more. This is a picture of a plaque, looking at plaque and no plaque as well. Looking at HDL, I think this is a really interesting area. We all are familiar with this plot from medical school. As your HDL goes up, your risk for cardiovascular disease goes down. And this was really exciting. This is the good cholesterol. So cardiology has spent a lot of time and money on HDL lowering trials. HDL increase, elevating HDL. And unfortunately, all of those trials did not help with cardiovascular disease. So the question is, well, if this is the good cholesterol taking all your cholesterol out of your vessels to your liver to excrete, why is increasing not helping? And so that really opened up another area of the concept of dysfunctional HDL. So it's not really the level, but unfortunately it's really how your HDL functions. And there's been numerous studies showing that in our populations of RA and HDL, RA and PSA, it's not the levels, but it's actually how well your HDL is functioning. And unfortunately in our patients, our HDL is dysfunctional. So there's a lot of assays out there to try to measure dysfunctional HDL, but really what the question is really, what is the mechanism behind why a patient with RA might have a dysfunctional HDL? So this is here just to remind us that HDL has a lot of different effects. In addition to the reverse cholesterol transport, it has many antioxidants as well as anti-inflammatory properties. So I just want to bring you to your attention. You guys have heard of Stan Hazen's talk, who's the keynote speaker at the beginning of this conference. In addition to his TMAO work, we are also working looking at this dysfunctional lipoprotein A1 that I just wanted to review. So their lab has discovered that in the good cholesterol, they were looking at mechanisms of why it becomes dysfunctional. So instead of having cardioprotective effects, that it starts promoting inflammatory effects. So what we know is that ApoA1 is really the primary protein that is in an HDL molecule, and it's responsible for the transport of cholesterol out of the circulation and into the liver for excretion. We know that during times of oxidative stress, which our patients have, MPO binds to this HDL and selectively oxidizes that ApoA1 protein, making it unable to do its cardioprotective function and rendering it dysfunctional. And in addition, we found that 20%, their lab has found 20% of ApoA1 within these plaques that are atherosclerotic plaques were found to be oxidized and resulting in a dysfunctional particle. So this is a little bit hard to see, but they further did studies within animal models of aortic plaque and normal aorta, and you can see here this sort of reddish staining shows the majority of the oxidized ApoA1 that is in red. They are further doing studies now looking at cohorts of over 600 patients, not with RA, but just in the normal population that are at risk, and it has tracked now this level with in the normal population with patients with increased cardiovascular risk. We're also looking at the oxidative stress. So this is once again just a cartoon picture of HDL, looking at not focusing on ApoA1, but also focusing on some related enzymes in the PON family. And as you go into an anti-inflammatory to a pro-inflammatory state, you see that the peroxidase activity goes down, and whether this could be some helpful marker to assess risk in our patients has also been looked at. So this is some early data in our cohort. So what we know is that the PON1 family, or the antioxidant activities of PON1, has been significantly reduced in inflammatory diseases, and this has been written about in SLE and in IBD, obesity, as well as in our patients with cardiovascular disease. And what we found is looking at a family of enzymes, aryl esterase has tracked really well in our cohort. So we're looking at PON serum levels in PSA and PSO and seeing whether or not they affect cardiovascular risk. So here, the first bar here is in healthy controls in terms of looking at PON activity level. And as you increase your Framingham risk factors, you can see that there are lower levels of peroxidase in our patients. And this is the psoriatic group. So just to end, I just wanted to review some of the things that we're doing here at the Cleveland Clinic. I know I mentioned that screening has been controversial about who should do it, how far should we do it, do we know how to do it ourselves? So this is just to remind us that our patients are less likely to actually be screened and treated. And even if our patients do have a cardiac event, this is an interesting study showing that initiation and adherence, even in secondary prevention, that we are not doing very well. So as you can see here, on day 30 after getting a heart attack and tracking them to day 180 after getting a heart attack, is that there is reduced treatment in our patients. They're not getting started on their aspirin, beta blocker, blood thinners as they are in patients without RA. And I don't know if that's because of the concomitant DMARDs that we're on, or that our patients, for some reason, are not putting on treatment as aggressively as those without rheumatoid arthritis. So what are we doing here at the clinic? And I'd love to hear what you guys are doing in your own practices. I know it's very difficult. The guidelines for AHA and ACC are constantly a moving target. How low your LDL should be, should you be put on aspirin or not? So we have and this is actually thanks to Gary, who had early conversations with me when I first started here, about, so what are we doing with all this data that we're seeing? What can we do in practice? And so we are lucky to have a prevention cardiology group that focuses all on primary prevention, and have developed a relationship with them to see our patients. So what I like is that our patients are starting to be discussed in these groups along with cardiologists to try to build some consensus, since there aren't any guidelines. They do a lot of support with patient phone calls. They have dietitians and exercise prescription. They are the ones that help us initiate antiplatelet blood pressure and statin therapy if needed. And they also help us go on to any further imaging that they might need to better risk classify them for their future cardiovascular risk. So what we have done is more of a system-wide approach where we are all on electronic record on Epic. And the clinicians here have what we call a hard stop. So if they have a patient with one of our diseases, and I'll show you an example in a minute, they cannot no longer chart until they answer a best practice alert, and they have to answer yes or no. Obviously, this is, might sound good on paper, but when you're in a busy practice, there are a lot of challenges to this, as we all know, and there's a lot of pop-up fatigue because there are other people in my practice with other interests and other best practice alerts. So we're not the only ones. So there's pop-up fatigue. And then there's some clinicians that I know that, because I track the data, that just hit no, no, no every time. And so I know there's some non-compliance that could occur in a busy practice. So here are just what it looks like in our system. If you have one of these diagnoses, that window pops up, and it allows you to automatically populate an order to prevention, as well as a diagnosis code along with that. So I do want to just mention briefly the CIRT trial. It was mentioned a little bit earlier by the other speakers that other people are, sort of interested in what we do in inflammation, and this is a trial by Dr. Ricker, who's looking at the use of methotrexate in patients without our diseases, but patients that have had a heart attack or stroke are at high risk, and giving them methotrexate up to 20 milligrams a week. And seeing if this can actually reduce the rates of cardiovascular damage in the future. So this is the CIRT trial. So I think in conclusion, we know that there's a lot of observational studies that have shown an increased risk in our population. We know that controlling this inflammation could have some benefits, and that we have a long way to really better understand how our drugs affect this risk and other surrogate measures that we can use to find people at risk sooner. And current recommendations, we can't really say that to a patient probably at this point, but maybe sometime soon, that being on this will prevent a heart attack, but sure, it does sure look like it will help lower that risk. So this is just a cartoon to remind us of that reducing risk is not as simple as doing one or two things, but there are many prongs and different approaches that we need to do to help our patients through this. So that's the end of my talk.